We are going to talk about increasing the enhancing skills. And please, Elliot, the stage is yours.
We good? Yeah. Well, first of all, thank you so much to the co-chairs for that lovely introduction. As I say, my name's Elliot Street. I'm the co-founder and CEO of Innovus Medical, and a physician by training. I'm then going to be joined, immediately I'm finished, I'm sure there'll be another introduction, by our clinical excellence lead, Dr. David Rawaf, who's going to follow this on from here. But I'm going to start by talking to you about what we view as the future of hysteroscopic skills training, and that being the use of augmented reality. So before I go on, I want to make a big thank you to Hologic. Thank you to the Hologic team for inviting myself and Dr. Rawaf to speak at your symposium today. We really appreciate that. And also thank you to Hologic for your continued commitment to driving the best possible standards when it comes to hysteroscopic skills and hysteroscopy training. Before we move on, a couple of quick disclosures for myself and Dr. Rawaf. So, as we mentioned there, we both work with Innovus Medical. We design and manufacture surgical training technologies, which we're going to be telling you about in this talk, and Hologic are one of our customers. So, just a little overview of what we're going to talk about, first of all. I'm going to begin, and David's going to follow on. And where I'm going to go to is the background to how we learn practical or surgical skills. We're going to talk about the use of simulation and the different types of simulation modalities that we use for learning practical skills. We're then going to talk about what we view as the problems with the status quo of existing simulation technologies, and then lead into what we view as the future and the use of augmented reality. Dr. Rawaf's then going to come on stage, and instead of just telling you our views, he's going to give you some evidence that supports this. So he's going to talk about some of the evidence base behind this technology. He's going to talk about the health economics behind the technology, and then finish with an overview of where we're going with our future research, which we'd invite anyone that's interested in to come and talk to us about. So let's talk about the phases of learning when it comes to practical skills, when we're talking here about hysteroscopic skills. And this is how we view it. And we view this continuum when it comes to hysteroscopy, laparoscopic, any other procedure. But let's talk about hysteroscopy, and let's talk about it from a simulated environment, because we know that learning these skills is holistic and should also be done in the clinical setting. Now, from a simulated environment, before we get our hands onto the simulators, which I know we all like to do, the first thing we should be thinking about is some cognitive training. And the way we break this down is what we call pre-procedural cognitive training. That's learning anything from how do I diagnose this condition, what's my management plan, how am I going to position the patient, how am I going to consent them, etc. Once we've learned that, we then move into cognitive procedural training. So what are the steps of this procedure? Typically learned with a textbook, and now there are other modalities. What we're going to focus on today is talking about physical procedural training. But I must also talk about the fact that whenever we're doing this continuum of training, we must think about data capture, feedback, and sending ourselves back into a loop to reinforce everything we've learned. But when we think about physical procedural training, we can break this out into its own continuum. So the first part of what we think about when it comes to simulation-based practical skills training is what we call part proxies. Now, from a laparoscopic perspective, that would be things like hoops and stacking hoops and threading thread through hoops. In hysteroscopy, it would be like the basic Gazia models for targeting. That allows us to gain the fundamentals of a skill. And once we have that, we're then able to move into what we call part procedure training. So this is where we're breaking a complex procedure down and we're learning distinct elements of it. So when we think about laparoscopic surgery, that would be the vault closure and a TLH. Once we've built all of those skills individually, we then want to bring those together in full procedure training. And again, when we're thinking about that, we do that in a simulated environment. And here are the way we think about the simulation modalities. So traditionally, we can break simulation down into low, medium, and high fidelity. And if you were to take this pyramid that you see on screen, and you were to turn it through 90 degrees, it roughly mirrors that previous continuum I showed you. So in our part proxy training, we often use low fidelity, basic box training. There's often a little bit of an overlap between part proxy and part procedure training between low and medium fidelity. But when we come to the full procedure training, traditionally speaking, we use high fidelity technologies to deliver that training. That's traditionally been virtual reality based technologies, but you can also put into that bucket things like cadaver based training. So that's the status quo. Those are the technologies and the learning continuum. Well, what about the problem that we're thinking about with those? Well, the biggest problem is not in the simulations. It's in the antiquated approach we really still do have to training today, and that's this idea that still a large majority of our learning curve is at the patient bedside. It's that see one, do one, teach one approach. And what we would like to see, as a company full of physicians ourselves, is that early learning curve has shifted more into the simulated environment. And the question is, well, Elliot, you've just shown us the modalities for simulation. Why has that not happened? And here are the reasons why. So first of all, existing technologies are very expensive. There's a cost barrier. VR is expensive to develop, expensive to deploy. Cadavers are incredibly expensive. And that cost leads into the next problem. And that's lack of access. So systems are often mainframe systems. They're not overly scalable. Excuse me. And there's very often not a distance learning solution, so we can do really high volume training. Now on to the next concern we have with the existing modalities, and this for us is one of the biggest ones, functionality. And when we talk about functionality, we think about haptics and haptic realism. Now where virtual reality is great for giving you data and collecting metrics, the haptics are simulated. If we want really good haptics, we use animal byproduct, or we use soft tissue, synthetic, or even potatoes. And the problem with all of that is, with all the best will in the world, a potato can't collect any data on how well you're performing. And so this tells us that there's a lack of integration in those modalities in our pyramid. If you want to complete your pyramid and complete your training pathway, you need to use a different technology for each part of it. Not only that, but there's no integration throughout not only the simulated environment, but into the surgical environment. Because what we know is that training shouldn't stop at the theatre doors or the office doors. And as of today, it doesn't need to. We're going to be talking to you now about this concept of hybrid augmented reality-based surgical training powered by a digital surgery platform. And that platform is known as Totem. As I mentioned there, Totem powers this evolving ecosystem of surgical simulators that we have that are connecting practice to procedure. And for those that haven't seen it, first of all, please come and visit the Hologic and the Innova stands in the exhibition hall, because the technology is there for you to get your hands on. But I'll talk you through this very quickly. So this is a hub and spoke model. These spoke models here are highly portable. They sit on a tabletop. And here is a model that holds different types of synthetic soft tissues, so different types of pathologies, dry lab models, wet lab models, etc. You then have a hysteroscope, a camera system, a light source, and it's plugged into a laptop, and then that laptop is running the Totem digital surgery platform. That platform does lots of things. So it gives you augmented reality overlays, triggers complications, it captures video footage, and lots of other things. And that allows all of that data and all that training to be fed up into the Totem platform here. Now, this is a big platform. We don't have time to go over it all today, but hopefully that gives you a little insight into this concept of hybrid hardware with a digital platform sitting over the top of it, best of both worlds. And this is what it looks like when it's being operated on. So this is a wet lab tissue model. This is our fibroid model, and you can see here that there's a fluid management system in situ. There's a shaver, and we're doing a myomectomy. We're getting what we call natural haptics. We're using the real devices. But while that is going on, we're collecting data on how well are we handling the system. We also, you don't see it here, have the ability to use augmented reality overlays to trigger complications. So bleeds, readouts, debris, all of those things, we use augmented reality overlays to increase the level of immersion. The great thing about this technology as well is that you have many different types of pathology, and so we can provide that. Here's a polypectomy, again with a shaver, different type of pathology, and again, if we wanted to, we could trigger complications while we're doing those procedures to put people under duress in a safe environment. When we think about augmented reality and data collection, it's not just about using augmented reality to make it an immersive environment. Another part of augmented reality is about providing real-time feedback and real valuable training. And this is an example of that. So in the top right-hand corner, this is one of our engineers, so forgive his hysteroscopic skills. This is one of our engineers using the platform, and on the platform we have all these sensors. And he's just in the uterus model there, navigating the system. And you can see in the bottom right-hand side, this is an augmented reality avatar. And the sensors on the scope are allowing us to track where the scope is in time and space. And you can see here that it changes from blue, it will then change to yellow and change to red. And what that's telling us is when that scope is going too far off the midline. Why is that important? Well, when we're in a training situation, we want to understand where are my hands and how does that translate into muscle memory so that I'm not causing discomfort to the patient. Really important in office hysteroscopy when we're thinking about that. So this is how we're thinking about using augmented reality, and we are using augmented reality to add new and different layers to the learning continuum. So I know I'm pressed for time, and you're going to want to hear all the science behind this from David, so I'll be wrapping up shortly. But this platform of Totem driving our hybrid simulators, we see as guiding the way to surgical success. The platform, which you can't see here, but you'll be able to trial, connects mentors, physicians, peers, and examiners to share best practice. Not only that, but the Totem platform is harnessing the power of data to transform surgical training. What the platform does is allows us to collect objective performance metrics which guide improvements in surgical techniques and operative flow. Not only that, but the technology is allowing us to unlock the power of practice. It allows us to capture video, which allows for debrief, providing this ecosystem for review, refinement, and mastery of surgical procedures. This is where Sergio is going to come on and tell me, Elliot, you're running out of time. Dynamic assessment and universal recognition is a really important part of this platform as well, where we're able to issue certificates, gain CME and CPD in an automated fashion. Sergio, how am I doing for time before?
-3 minutes.
I'll stop there. There is a video here where everything I've just said is coming out of the mouth of someone else, because I think that's important for credibility. I'm gonna flick through that, because now we're going to move over to David. Now, before we do, let me just skip through that. My summary then, Sergio, thank you for giving me the time, is hopefully what you've just seen today is the new gold standard for surgical training.
Now our next speaker is David Rawaf. He's a surgeon, a researcher, technologist, innovator, and policy developer, and as well as studying and working in both UK and USA. And David works in multiple academic roles of Imperial College or Women's Health Organization and more. As the clinical excellence lead for Innovus Medical, and he has many roles covering validation, accreditation in Innovus. And he's going to talk about overview of augmented reality and data-driven training in hysteroscopy.
Thank you. Thanks very much for the introduction, and Sergio for giving us the time today to talk about some of the data. And Elliot's given us a wonderful high-level overview of what it is that we're trying to achieve at Innovus. So I'm going to dive a little bit into a Kirkpatrick level approach to training. So we think about the Kirkpatrick Pyramid. It's 4 levels. And what I want to talk to you about is the first level: how do trainees like this method of training? The second level, what skills are they achieving? The third, is that skill being translated into the OR? And the fourth, what is the benefit to the organization? And then we'll talk a little bit about some of the proposed studies that we're planning. So I'm very excited to share with you this data. Sergio, if I'm running out of time, just give me some waves and I will speed things up. So the first pilot study, this is with 45 minutes on one of our simulators. Now, this is with a laparoscopic simulator, but a lot of the approaches are very similar. 45 minutes on the study. These trainees were having all sorts of metrics that were being looked at. We also measured them subjectively as well as objectively. And we were getting them to do a lot of lap pass tasks, which are the basic navigation tasks for laparoscopic surgery. And what we found in those 45 minutes is that the surgeons, now the first 2 figures are for the appendix. The second one's more applicable here, the vaginal vault closure. We were getting up to a 40% improvement on completion time and up to a 60% almost improvement on economy of movement, so distance traveled in meters. And this is a statistically significant study. We also measured their self-confidence. It increased dramatically. This is a Likert scale out of 5. Now, we escalated that from 45 minutes to 2 weeks. Now, each of the trainees, because of the hub and spoke model, which Elliot told you about, where you can have a portable unit, these trainees took the portable unit back home with them. They were training on this simulator at home for 2 weeks. And you can see in just those 2 weeks, we're improving completion time up to 55% and up to 39% on distance traveled. So some better figures coming out of there, certainly for the completion time, which is key as you'll see later, for the benefit to the organization. And this is an ongoing study. We're up to 15 people now. The cohort study, this is very interesting. This was actually presented at BSGE last week. And as you can see, Rebecca Malik and her team on the bottom right winning an award for this presentation. So this is not my work, but it is with our technology. So there were 60 trainees. There were 3 cohorts, basic, intermediate, and advanced. And we were assessing not just their skills and their confidence, but also their knowledge. The intervention was a laparoscopic course, obviously. And we repeated the survey and the assessment at the end. And you can see similar metrics that were being assessed. And the kind of procedures were actually ranging from simple to more complex procedures. And we found that despite having, certainly for the basic and the intermediate groups, despite having low confidence levels and low understanding, they were coming out with some fantastic ability and improvement in their confidence, their knowledge, and their skills, as well as the actual metrics of smoothness, time, and speed. So I'm very excited to see that this is happening over 4 days, spaced out over the space of around 9 months. So we touched on levels 1 and 2. Now we need to think about the translatability. What does this mean? So we had to do this via a systematic review. This was sponsored by Nottingham Trent University. It wasn't done by us, so just to be completely transparent, we tried to make it as objective as possible. N equals 26, following the exclusion criteria, we found that augmented reality training, so that the training where we have a real tissue model and we're measuring metrics and applying augmented reality overlays, is a highly effective modality. It's recommended to have multimodality training, but as a modality itself, it actually can replace cadaveric, virtual reality, and traditional box trainer. It's preferred, and it provides faster skill acquisition in comparison to the other modalities. And it improves procedural success in the OR because it reflects the clinical scenarios more accurately. It provides the natural haptics that Elliot was talking about. And certainly when we compare it to the cadavers, where we have a lot of formaldehyde, which actually defeats and destroys a lot of the mechanical properties of the tissue, as we all know, it also removes the ethical and financial implications to do with cadaveric work. So then we switch gears into the outcome level 4, the final outcome of the Kirkpatrick Pyramid. What is the benefit to the organization? And this is one example for the appendicectomy. We can extrapolate this to pretty much any type of surgery from any type of speciality. And we chose the appendicectomy because we've proven that we can increase the efficiency, reduce complication rates, and improve the surgical skill. So what does that mean in terms of monetary value? Forgive me, this is not in euros, Sergio, but we've done it in pounds and dollars, and this is really the kind of conversation that we need to have with our hospital leaders. If we are assuming that a 10%, so if you remember a little bit earlier, we had almost a 60% completion time saving. If we take 10% of that 60%, so just the 10%, we can save £79 per patient. If we take 100% of that 60%, we're looking at £455. We extrapolate that across all the hospitals in the UK and the US, and you can see the figures there are quite astounding. And those figures take into consideration the cost of the training equipment from Innovus. And in terms of hysteroscopy, obviously that's why we're all here. This is the proposed study by Rebecca Malik and her team. What we're planning on doing is running alongside those laparoscopic courses that we had, the 4 days, with the same numbers of 60 trainees, that we would do theoretical lectures plus wet and dry lab work, similar to the course yesterday, with some fixed benchmarking. And the fixed benchmarking will be from faculty as well as the trainees themselves. And that way we are able to see how they've improved, not just at the beginning and the end of the day, but also throughout the 4 courses. And we're planning on doing the same thing with a separate cohort of 30 minutes of dedicated weekly HistAR time. So we're not just proving this works on a quarter course, but also on a weekly basis. And the idea is to expand this to beyond just clinicians. The workforce of tomorrow is changing, as we all know, especially in the West. And so looking at the nurse practitioners and outpatient trainees in the clinic is going to be really important to make sure that they are safe and at a competent level. So in summary, I'm really, really happy to say that we've done as much as we can in terms of proving and validating this augmented reality approach. However, we need to deep dive into complication rates, increase patient turnover. If we can save time, we can have more patients on the list. And things like, can patients go back to work and contribute to the economy quicker? So that's really something quite interesting. But otherwise, we have a strong evidence base now, and we know it's preferred. So potentially, again, we're looking at a new gold standard.